I will start with the first question for our first two speakers. What about your experience with IV iron and postoperative infections? Have you noticed a higher incidence of postoperative infections in your practice? The first two speakers, can you answer this question?
Well, we are actually starting a pilot of treating patients with IV iron. We know that there are some studies in which this postoperative infections is a concern, but to my knowledge, most of the studies have not found an increase of infections after IV iron administration in these patients.
And also you have to remember that anemia is also a risk factor for infection.
The second question, what are your triggers for intravenous iron?
Yeah, so absolute iron deficiency is a ferritin less than 100, and relative functional iron deficiency is less than 300 with a transferrin saturation less than 20. That's it.
Okay. Did anyone notice increasing bleeding in postoperative periods in anemic patients? What is your advice how to manage this problem with red blood cells or other blood product transfusions? So did anyone notice an increase in bleeding? Maybe, Luc, you can answer that question. So I think it's a question about viscosity.
Yeah, well, if anemia is the result of serious dilution, you also dilute, of course, your coagulation factors. That might be a reason. It's very difficult to answer, but if you look at the data provided by those two studies I alluded to, one of them clearly says there was no difference in reoperation. So the answer would be no, unless you have diluted your coagulation factor to such an extent that coagulation as such is a problem and not anemia.
Philippe, would you like to comment on this?
Yes, I would like, because I think there is, beside the effects Luc was just mentioning, there is a relationship with hematocrit in that way that when you have a higher hematocrit, you actually, because of the mixing effect of the red blood cells, you will bring platelets and coagulation factors closer to the wall. So there is probably a cutoff value on which it might enhance bleeding. The question is, to my knowledge, there is not a real cutoff known where you should go. But it's for sure, if you have a very low hematocrit, combined eventually with also low clotting factors, it might be wise also after you have given the clotting factors and there still is some issue to give some red blood cells.
Okay, thank you. A question about preoperative assessment. What's in your daily practice in the OLV? Are most patients detected early enough for treatment? Or do you regularly use the short-term regime with iron, etc., preoperative as suggested?
So as I said before, we're starting all this. We have applied a lot of topics in the second and third pillar, but we're starting to apply the topics in the first pillar. We would love to be able to detect anemia early enough. This could be solved by, for example, having a better communication with primary healthcare, as in the GP or the referring cardiologist. But often that is not possible. So here we are starting all this, so I will be able to answer to you this question in the future.
Thank you. A question for Philippe. Could albumin solution in priming can minimize the damage of glycocalyx during bypass?
It's a bit of a difficult question in that respect, that albumin will increase the viscosity. And we do know there is an impact of viscosity on the glycocalyx. On the other hand, Proteins by themselves have a protective effect of the glycocalyx. There have been experiments where they did the hemodilution with plasma in an animal model, and they could show a better or less integration of the glycocalyx compared to the same hemodilution with a crystalloid or non-crystalloid solution. So there might be a benefit, but I'm not sure whether we have sufficient evidence at this moment in time to advocate to use that as a standard routine. I don't think we have that evidence at this moment.
Does albumin add something to the platelet counts after bypass? So do you see a difference between in platelet counts if you use albumin or not?
That's a different story. That highly depends on what type of equipment you're using. Albumin is known that when it's available in the priming, that it will actually give a very thin layer on all foreign material, which has no direct or very little receptors for platelets. So it means it can attenuate the interaction between proteins and platelets and the material surface. On the other hand, if you have a coating, which many centers do have, of the whole circuit, then this effect is probably not necessary because most of the coatings actually have in an artificial way the same effect.
Okay, thank you. The recent results of PREVENT bowel surgery and upcoming EACTAICs in cardiac changed the entire landscape for preoperative IV iron. Could you comment on that, Sarah? Or
yeah, so yeah, the evidence on outcome. The evidence on outcome, it's still controversial. That's why I said that IV iron might increase postoperative hemoglobin and decrease red blood cell transfusion. I don't know about the EACTAICs because I think it's still not finished, but the PREVENT, correct me if I'm wrong, but they included patients, they included anemic patients, and then they excluded patients with known cause of anemia. So did they really include iron deficient anemic patients? I don't know, but anyways, the evidence in the impact on outcome, it's still controversial. But the guidelines from 2023 from the European Society of Anesthesia recommend to treat iron deficiency anemia with IV iron, preferable to oral iron.
thank you. I have two questions for Philippe. Talking about the DO2, do we talk about the index DO2 based on the BSA? I suppose yes. Should it be based on the lean BSA?
That's a very good question, but lean BSA, there it depends whether you're talking about a very muscular man who is, because of that, having some overweight, and someone who is real obese because of fat. Now, the best technique, because there is always a lot of discussion about goal-directed perfusion and looking only to DO2, which in my point of view is a big mistake, because the DO2, that's what we know, what we give to a patient. However, if you give something, you have to see what is coming back in return. And actually, you get the information by the amount of carbon dioxide produced, which you can easily measure during cardiopulmonary bypass. If you see that there is still an increase in this production, then probably you should actually hasten the DO2. And it's very nice because it helps you a lot if you have severe obese patients to define what is the optimal flow and the optimal oxygen delivery during cardiopulmonary bypass. But oxygen-derived parameters are not very well in actually detecting anaerobic metabolism in opposition to carbon dioxide-derived variables. So for that reason, I would, if you have a lot of these patients, please add also carbon dioxide measurements to your cardiopulmonary bypass, and it will help you a lot in defining the optimal flow.
Thank you, Philippe. Another question for you. Do you prefer to retransfuse leftover CPB blood directly or through the cell saver?
I think that comes back to all presentations this evening, because it all depends on what was your strategy. I think the strategy in my hospital is to limit as much as possible the amount of fluid given before cardiopulmonary bypass. We put a lot of attention on the amount of priming volume, which can be even for minimal invasive as low as 650 ml total circuit for adults. And that means if you have these low numbers, in the majority of cases, you can push it inside the patient, especially if there is a little bit of vasodilation by the anesthesiologist. So if you have severely overfilled patients and you had no time to get rid of the volume during cardiopulmonary bypass, then I think you have two options: or you do ultrafiltration, trying to preserve at the same time the clotting factors and the platelets, or you go over a cell salvage device with the expense that you will lose some, depending on the volume you have to recuperate, you will lose some of the platelet factors and the platelets. Okay. So there is no uniform answer, I'm afraid.
Luc, would you like to comment?
Yeah, just one small remark. I completely agree with you, Philip. Only thing is I found a couple of papers where they looked at the oxygen transport capacity and the membrane quality of red blood cells after cell saving. And surprising or not, their conclusion was that those red blood cells are really okay. In that short period, they seem to be not harmed at all by the cell saving. But we worked together for a long time. I 100% agree with you. Try to get the pump blood into the patient if possible at all.
I would agree on the red blood cell, but that was not my point. My point was I know. Cell salvage, that you lose the clotting factors.
Exactly. Okay, question for Luc. Restrictive versus liberal transfusion, going by physiology, would you consider different transfusion trigger for a very low EF patient on multiple inotropes or a mechanical support device?
That's a tough one. Certainly in those patients, I wouldn't go too low on hemoglobin, for sure. I would rather go for at least 8+. Inotrope I don't like at all. They will increase oxygen consumption anyway, but you may need them. So don't go too low. That would be my answer. On the other hand, I didn't touch the subject because of lack of time. It's not only DO2, of course, it's only extraction ratio. But that is a much more complex thing. But an interesting thing would be to look at the extraction ratio of patients. As we all know, in anemia, the body can sort of cope with anemia by increasing the extraction ratio. Only thing, the heart is very bad in doing that, because the heart can't do that. The rest of the body seems to be able to do that. And it's an old study, but it's a very interesting one, that in cardiac surgery, if your patients come in with an elevated extraction ratio, meaning that they sort of, for example, in anemia, if they come in with an elevated extraction ratio, if you give those anemic patients red blood cells, their extraction ratio decreases. And it doesn't happen in patients with a normal extraction ratio. So it's a very interesting thing, as if there is a sort of oxygen deficit in the first group of patients. I can't give a definite answer to your question, but I would go for an hemoglobin that is not too low.
And look, would it trigger you in a very bad patient with a low ejection fraction, already on high dose inotropes? Would it trigger you to put in an ECMO, for example? Or would you transfuse and see what happens? I don't know, it's the final part of this question.
It's even more difficult because I've shown that transfused blood is not ideal blood at all. I would probably not go too quickly to ECMO unless it is really needed. But as such, it's, as far as I know, not an alternative, first of all, to transfusion and hemodynamic optimization. Finally, it might be a solution, of course. But then you should really, in my opinion, you should really look at oxygen consumption. You need a swan for that, or at least a swan helps you to do that. Would be a good idea to look at.
Do you have a comment on that, Philip?
No, I can only fully agree with that statement.
Okay, thank you. Okay, is low diastolic pressure while coming off CPB related to anemia, or could it be related to anemia? And it tends to improve with transfusion. Philip, would you like to comment on that?
That's a bit of a difficult question to answer because low diastolic pressures can be caused by many reasons. Viscosity certainly is one. If you have a very low oxygen supply, it also gives some additional vasodilation, but also the type of surgery you did, the amount of material used in there can all be reasons why you have an excessive vasoplegia. I think we all know that. So it's a little bit difficult to answer the question. But I think you first have to exclude by transesophageal echography whether there is another reason which could explain that before you go to other steps.
Mm-hmm.
Of course, if you would have an extremely low hemoglobin, let's say 6, I would be personally in favor of transfusing. And probably in a bad cardiac function, I would never start weaning even if the hemoglobin is only 6.
Okay. There is another question related to this question. What's the desired hematocrit when you use ECMO or other kind of circulatory support? Do you have a lower cutoff value, Philip or you?
For me, it means what is the type of ECMO you're placing. What do I mean by that? Is it a partial support because the heart is not capable to give full support? In that case, it could be sufficient that you only deliver 30 or 40% of the required DO2, so that will have an impact. When it's full support, then I think there play some other reasons, as again, you have to see what is the response of the body to what you're giving. And so it could be that if you have hemoglobin 8, but everything is under control, there is an acceptable hemodynamic status, there is no further increase or even a diminishment of lactate production, then probably you're doing well. So it depends a little bit of the circumstances.
Okay, thank you. I have a question. Maybe Luke can answer it. Tranexamic acid infusion during CPB and during surgery. Is there a strong evidence about using it continuously on pump?
The answer is yes. There is a trial, and I always forget the name, but Sarah will remember the name. There is an international trial that looked at it, and the answer is yes.
Well, it's in fact a class 1.
Yeah, it's a class 1. I mentioned it.
Recommendation. Whether you use it continuously or in bolus is also depending on the dose you're using. Some people like to use it as a bolus, but they give rather high doses, or you can actually use a limited dose and give it continuously. We in our clinic, we are using a bolus with continuous infusion. So it's depending on your choice or on the center you're working. And I hope this is an answer to your question. I have also a question for Philip. Does pulsatility during CPB would add something to your oxygen delivery?
It certainly will, because what you actually do is you will have a better energy supply to the microvessels and they will go open. However, there is a counter side of that. Everyone believes that they give pulsatile perfusion, but in general, the problem is that the pulsatility you can generate in the patient is not enough to get these effects. What do I mean by that? Because of the choice of cannula, and today we have worse patients, so often the cannula size is reduced. You lose all of the energy at the cannula level, meaning that the pulsation you get in the patient, and especially at the level of the smaller blood vessels, is not enough to create this effect. Better effects have been shown when the patient has, for example, preoperatively an intra-aortic balloon pump, to combine that because it generates a better pulsatility.
Okay, thank you. And Luke, would you like
just
to
one
comment?
comment? Yeah, just one comment. I agree with you, Philip. And if you can make sure there is real pulsatile flow, the physiological advantage is that the strongest trigger for endogenous NO production in a vessel is pulsatility. And if you would be able to do that, that would be probably the best way of having a sort of natural vasodilation of the microcirculation, and much better than any other drug, most probably. But of course, you should be able to organize real pulsatility, which is probably more of a problem.